So we're back.
I guess the movie that made that famous is Poltergeist, and perhaps Poltergeist 2 and 3. I've not seen them. Have you seen them?
When I was a kid, yeah.
I mean, I know that, like, creepy, we're back.
Yeah.
But, yeah.
But we're not creepy. And,
Nope.
And maybe you missed us.
Maybe you didn't even know you missed us because you're just discovering us. Great. Welcome. So we're going to start making the podcast again, but in a sort of new format. You want to talk about that?
Yeah. So we have a couple of collaborations coming up over the next month or so. So you'll get to hear some conversations with some interesting people and friends we've met along the way. And then over the summer, our goal is to have an every other week podcast with interviews. There's still so many topics that we weren't able to cover in the first season that we want to dive into in the second season. So many things in medicine that are being outlawed.
What an exciting time. So today's episode, we had the chance to talk with Jenny Wetter from RePROs Fight Back. Jenny is a policy expert on sexual and reproductive health and also hosts a podcast, RePROs Fight Back, where she talks with a bunch of different guests covering different topics on sexual and reproductive health, and both conducts excellent interviews and then herself has a really outstanding educational perspective on many, many different topics, sort of broader than we look at probably in Outlawed.
Right. There's some, parallels to what we discuss, but what she's doing is really cool. And she recently released this most current 50-state report card around sexual and reproductive health. That's an incredibly useful resource to learn more about what's happening in your state and what are areas where your state can do better. Jenny, would you like to introduce yourself and tell us about your amazing podcast?
Yeah. Hi. First, thank you so much for having me. I'm so excited to be here on Outlawed. I am Jenny Wetter, and my pronouns are she, her, and I am the director of the RePROs Fight Back initiative at the Population Institute, and I am the host of our podcast, RePROs Fight Back. It's a sexual reproductive health rights and justice podcast, and we kind of talk about anything and everything related to sexual reproductive health rights and justice, kind of what's happening, what needs to change, and how can you get involved in the fight to fight back. So we do a lot of advocacy related things, and I have so many great conversations.
Just kind of listening back through some of your recent episodes and definitely looking at your report card that you guys just put out, like you guys are doing really cool work.
Oh, thank you.
Yeah. So when you started the podcast, what was your goal?
This was a little over a year into the first Trump administration, which is really sad to be saying first Trump administration, but that's okay. And there was so much happening around sexual and reproductive health. There was so many ways it was being attacked that it was hard to keep up. And so we wanted to make sure that people had a place to go where they could get kind of consistent information. And this is definitely something I never saw myself doing. It was like one of those things that gets floated at a board meeting and you're like, okay. And I wasn't really in on it. And my boss at the time was very much like, I think you should do this. I think you should host it. Like, you should do this. And I was not on board.
So Jenny's boss told her that she had to do a podcast. How do you respond when your boss tells you that you have to do a podcast?
I guess you just clear your schedule, as it turns out. It sounds like Jenny's boss gave her funding, I guess, to sort of...
And time.
And infrastructure. And my boss sort of did the same things, right? I don't know. So that was good. I think you just say yes.
Yes.
Yeah. Well, it's a nice thing that someone thinks that anyone else would want to hear your voice on a podcast, or that you might be smart enough to talk about something, right? So it's it's a flattering thing for someone to say.
Yeah, I think so. You just say yes.
I reluctantly agreed, and then he gave me this wonderful gift of like, that was all of his input. The rest, he let me build it how I wanted. It was whatever I envisioned, and that was really wonderful. And so I wanted to make sure, as we were doing the podcast, that it was a place where people could come to learn about the issues if they were unfamiliar. So I wanted to make sure we were building, if we're talking about the Hyde Amendment, I don't want to assume people know all the things. I want to start from ground zero of like, you don't know what it is, building up to what you can do now, and then always ending with how can the audience get involved and how can they fight back? Because I didn't want people to just feel overwhelmed by the negative things that were happening. It was really important to give people ways that they could take action and get involved. So that was really how I envisioned the podcast from the beginning. And then it was just also really important to me that it also brought in a reproductive justice lens, and was being as inclusive as possible all along the way. And over the years, that has grown to change as things have changed, and it has been a wonderful experience. So one of the things I like to talk about and keep bringing up is sex education, but it is one of those like evergreen issues, but there's not like an immediate issue or bill around it happening right now that is attacking access. So all of a sudden, like those kind of evergreen things like fall lower and lower on my priority list. And I hoped when we switched from a bi-weekly podcast to a weekly podcast that we would be able to do more of those things, but there's still just so much happening that it is kind of hard to do some of that prioritizing.
Going back to sort of the current events and the current events work. I mean, when we had the chance to be on your podcast, you talked about creating really important or guiding people to important sort of resources that they could use to look things up. And you mentioned the Guttmacher Institute, but you just created something similar, right? And so I was hoping that you could talk about the work that you've done with the 50-state report card and sort of what was the goal of that and what should people use it for? And then we'll put in the show notes how people can access it.
Yeah, so we started the report card in 2012. It followed on the legislative year of 2011, where you had like a lot of red state takeovers and saw this huge wave of anti-abortion legislation get passed. And, I went home to Wisconsin and was talking to some people, and it became clear that a lot of people might have known about things that were happening when there was a state where something particularly egregious happened, like, really bad legislation in Texas that got national attention. But then you started talking to them about like some of the other sexual and reproductive health things that were happening in their own state or just general policies in their own state, and they were a lot less familiar. So we decided to take a step and try and fill that gap to make sure that people were not just talking about some of the sexual and reproductive health thing in silos, which I think is really, it's important that it happens, that abortion is getting that attention, but so often there's like this big focus on abortion, or right now there's a big focus on like gender affirming care bans for young people. Also really important. Those are getting attention. But we need to talk about sexual and reproductive health as a whole, because it is more than those things. That we need to make sure that young people are getting sex education. We need to make sure that states are expanding their Medicaid coverage, because Medicaid plays such a huge role in sexual and reproductive health. Over 40% of births in this country are covered by Medicaid. So it is really important that we are talking about those programs as well. So we wanted to make a resource where people could see how their state was faring on sexual and reproductive health compared to other states. So we have a annual report card we put out. It has like 3 major categories. We look at prevention, affordability, and then access. And we have 11 indicators we use. And then we give states a grade A through F. And you can now go to our microsite and see how your state compares overall compared to all the other states. Unfortunately, not great, probably. We only have 5 states that get A's and 25 states that are getting an F. And then you can also see this year for the first time, if you want to see how your state compares on sex ed to all of the other states, you can click on a little toggle and look at that. So I think that is I really love the tool this year where you can look even deeper than you have been able to in previous years.
Yeah, it's really user friendly. Like I don't know, I spent a lot of time with it, just kind of playing around and looking at different metrics. And North Carolina gets a D-.
I saw that.
Not great. So we have some opportunities to improve our access to sexual and reproductive health.
Yeah, that's definitely how I see it, right? Like, you can't ask for change if you don't know where your state is failing or succeeding. And even in states that got A's, nobody gets 100. And these are state level grades, so it often hides access even within those states. So yes, California gets an A, but there are still problems in California. There are still areas where it is hard to access services. So there is work to be done in all of the states to improve access to sexual and reproductive health care. But the report card gives advocates a place to start when they see where their state has gaps, that they can start pushing legislators to make policy change.
All right, so let's break down why North Carolina got a D-. And the report card's pretty helpful. So the thing that we're familiar with are the abortion restrictions in North Carolina. So North Carolina bans abortion at 12 weeks, except in a few limited exceptions, and requires the 72-hour waiting period, which we know is really, really inconvenient for patients and is a huge barrier to patients because they have to have 2 in-person visits, one that's 3 days before an abortion procedure or medication abortion.
Yeah, and we've talked about how that, in many cases, delays care for patients who know they want abortion care.
Yeah. And then the North Carolina, in the last legislative session, also banned evidence-based transgender care or gender-affirming care for individuals under 18.
That's correct.
Both surgical and medical care. And so that affected its grade. And then also in the North Carolina does have sex education, but in sex ed, it portrays heterosexuality and anything other than heterosexuality and anything other than cisgender gender identities as shameful, unacceptable, and illegal. And we know that those are just identities, not without a judgment on them. Let's talk about what North Carolina is doing right. And the report card highlights some areas that we're doing right. So talk about sex ed.
So North Carolina does mandate comprehensive sex education, which is in public schools, which is incredibly important for kids. We have expanded Medicaid, which is a really big deal. Although if the federal contribution drops at all for Medicaid, we have a trigger law on the books that would get rid of Medicaid expansion, which would mean potentially overnight 600,000 people would lose their expanded coverage. So it's tenuous, but for now we have a good score there.
And that's wild because the state, so many of the people in the state work so hard to get Medicaid expansion for years. I mean, we had the chance to talk with former Secretary of Health, former director of the CDC, as well as the head of North Carolina DHHS, Mandy Cohen. And she talked about how for years she had made the case for Medicaid expansion in North Carolina, and that finally they get it over the finish line, and now on the federal end, they're just going to take away the funding.
Right. And it's just hanging by a thread.
So the other things we do well on are, so we have Medicaid expansion, you mentioned. We do have Medicaid family planning, which is access to contraception through Medicaid, even for people who don't have comprehensive Medicaid benefits, and oftentimes some access to primary care through that program as well. Those waivers are really important to getting access to care. Again, that feels a threat because the federal government is removing funding for Title X clinics, which is access to contraception for low-income individuals, and shuttering a lot of clinics, trying to defund Planned Parenthood. So maybe we would hypothetically have access to those services, but the clinics that provide those services would be gone. So, right. I mean, it's a real threat. And then we do have the 12-month expansion of Medicaid for people who are on Medicaid only during pregnancy. And we know that the year postpartum is a really important time for health. Many times there are chronic conditions identified during pregnancy, which previously people only could get coverage in the 60 days after delivery, that immediate postpartum period. But it's not like your health needs go away after those 60 days. Right. If you have a behavioral health condition like depression or postpartum anxiety, which are really, really common, identified in those first 60 days, it's not like those are going to be treated. And so access to ongoing care is really important. If you had diabetes during pregnancy, you need access to care to continue to optimize your health, either in general, but also if you want to get pregnant in the future, we want that pregnancy to be as healthy as possible. And then one thing that really stands out to me, and I've worked on a team with some research that's coming out about this, is access to contraception. We know that people often initiate contraception early in the postpartum period, hopefully before they start having sex again. But that may not be the contraception that they want to use long term. And so people need time to transition. And then, contraception is not one size fits all. So sometimes you have to try out some different things to figure out what works, and ongoing access to care facilitates that.
Yeah. And we've talked before about how pregnancy is like running a marathon. It's sort of a stress test on your body. And so for a lot of people, they find out they have some other medical complication during pregnancy because it kind of brings to light what's going on with them. They're getting regular screenings during pregnancy. They may find out, like you mentioned, gestational diabetes or hypertension or other things that have impacts on their lifelong health, and being able to have access to care in that year afterwards. They can, I remember when we didn't have that year of expanded coverage, we would rush to get everyone into their appointments within 6 weeks. And it's like virtually impossible to get into a PCP within, 6 weeks.
Totally.
Like that's just not feasible. So like having that year, it kind of takes some of the stress out of getting all those appointments kind of before coverage goes away.
Yeah. So it is a mix, right? There's some positive things, but there's also some really negative things that hurt people's health here.
Yeah. And there are a lot of people that have been working very hard for many years to make access better and to kind of chip away at some of these problematic areas. And there's a lot of work to do. Yeah, in thinking about North Carolina right now, there's a bill that has just been submitted to limit consent for minors. So minors in North Carolina already have to have parental consent for abortion care, but now they're trying to restrict access and force teens to have consent for STI testing and treatment, contraception, and mental health, which right now teenagers in North Carolina have access to those services without parental consent. And I think teens are not necessarily comfortable telling their parents that they're sexually active. And if a teenager has a sexually transmitted infection, they don't tell their family, that doesn't get treated, their risk of infertility or other complications from an untreated infection has potential lifelong, ramifications. And so I think, these bills that are like named like something about parents' rights and parents being involved in the exam room kind of thing. And I think there's this misperception about what's really happening, and kind of like, all right, people, let's get on planet Earth. Like the reality is teens are not necessarily going to talk to their parents about sex, but teens are having sex and teens are at risk of pregnancy, and let's give them the services that they need.
And then like back to the like sex education, right? I was in Catholic school. I had sex ed from a nun. As you can imagine, it was neither comprehensive nor medically accurate, very much shame-based. Like all of those things put additional barriers on young people accessing that care. And then if you also have to have parental consent on it and you've been taught like that shame-based, like that's going to prevent you from having that conversation and will then prevent you from trying to get that care. So again, all of these things are interrelated and interconnected. And if you don't have the ability to access contraception, well, then you might have an unintended pregnancy, but then you can't access abortion either because you have parental consent laws. So all of these things interact to impact people's access to care. And young people need to be able to make those choices. Oftentimes, young people do it in concert with their parents, but not everybody wants to do that or is able to do that. So we need to make sure that people have the ability to make the healthy decisions they want to make about their future.
Yeah. The interesting thing about the North Carolina law is it does allow teenagers to consent for things that are pregnancy related. So if they get pregnant,
always boggles my mind. Always boggles my mind. You can't consent to an abortion or birth control, but you can consent to pregnancy? Like, what?
Yeah.
It is really hard to talk to my adolescent about sex. And I'm pretty comfortable talking about sex, but they're just challenging conversations. I don't know if you've had that same
Well, I mean, we both have 12-year-olds, and we're entering into the time where like there are certain conversations that my son just like shuts down. Like he just doesn't want to have those conversations. But
I don't know. I mean, I would be great. Yeah, I don't know. My kids happen to have sex ed in school, right?
Yeah.
I know that. And so they do get exposure to it. And we want to create a comfortable environment. But the fact of the matter is that, on both ends, it can be uncomfortable. And so you need more resources for people to stay safe, be educated about sex. That's going to be a part of their lives for the vast majority of people. And so, I think education is just like more resources is better.
Yeah. Yeah. And back to that, like knowing places with good resources. Advocates for Youth has a great video series called Amaze and Amaze Junior for even younger kids that get into like a lot of sex ed and sexual health related issues. The Amaze Junior starts like really young and like with basic, simple like consent and things. I have not watched all of them. Obviously, I don't have kids, so like I haven't seen all of them, but I've definitely seen some examples, and it's a great resource.
My son has health class this semester, and so it's like half health, half PE, and so it's like one of the electives. And so I was like, well, what have you learned in health class? And he was like, he clearly did not want to talk about it. He was like, we learned how to put out a grease fire. I
had valuing your sexuality. And I learned important things like condoms don't work. And the Mean Girls version of sex ed, you're going to have sex, get this horrible disease, and you're going to die. So it was really helpful navigating my sexual life later.
In medical school, I think I've told you this story, but in medical school, maybe we shouldn't include this, but so one of my friends acknowledged that, I don't know, it was like in our repro block maybe, and she said that she had learned in high school that people could tell when you had sex because your hips got wider. Like when you lost your virginity, your hips were going to get wider, and so that people could tell. And she was only questioning that myth in medical school. Right? And then another friend said that she thought that the rhythm method was the rhythm at which you were having sex.
So if it's like a 3-4 time, you're fine.
Yeah. Exactly.
Great. See?
It's a waltz. had trouble, to be honest, keeping up with everything that is coming out of this administration. And as an abortion provider, I'm pretty worried, right? I'm in a state that already has abortion restrictions, but I'm pretty worried about what's happening on the national level. And I noticed you have a few episodes recently where you talk about some of the big issues. And the ones I'm thinking about really are this ruling around EMTALA potentially, and then also sort of what's going on with access to medication abortion. So I was wondering if you could tell us a little bit about the EMTALA case and where that is and what happens with these emergency abortions.
Yes. So EMTALA, it's the Emergency Medical Treatment and Active Labor Act. Sorry, y'all. You get so used to the acronyms, and all of a sudden it's like, what does that actually mean? It was passed, I think.
I don't think I could have said the acronym.
Nope, not me either.
That's fine.
That's why we asked you.
It was passed, I think, in the 80s, if I remember correctly, and I was very young at this time, so I don't remember it happening, but a lot of this was back in the day where a lot of hospitals were patient dumping. If somebody didn't have insurance, they didn't want to take care of them, and they just dumped them and left them for another hospital to deal with. And so Congress got together and passed an actually helpful law saying that you cannot do that. You need to at least stabilize the patient. You need to treat them. And when Roe fell, Biden clarified that that includes abortion if that is the treatment that is needed. And EMTALA regulates for life, but it also says health, which is important because some states' bans do not include health exceptions. They only have life exceptions. So Idaho is one of those states, and they had a very strict, one of the strictest bans, basically a complete ban. It has to be like your life is in imminent danger before you can get an abortion. And Idaho was sending about 5 patients a month out of state to get abortions because they couldn't get them in the state. So the Biden administration sued, saying that this was a violation of EMTALA, which meant states could lose their federal funding, so Medicaid funding, if they did not follow EMTALA. And Idaho was like, not going to do that. So it started working through the courts early last year. And the Supreme Court was like, actually, we're going to look at that. And it had not worked its way through the court system yet. And the Supreme Court heard the case last year. And they decided, actually, our bad. We picked this up too early, so we're going to send it back to the states. I'm sure it had nothing to do with the fact that there was an election and they didn't want to say that people could die instead of getting an abortion, but that's just me. So with this new administration, they decided they are not going to continue that lawsuit. So that case has been dismissed. However, in preparation for knowing that that was likely to happen, St. Luke's Health System, which is the largest health system in Idaho, filed a suit, suing under the same grounds that the Idaho law violates EMTALA. So recently, a judge put a protective order in place saying that they could not implement that super strict abortion ban. Unfortunately, it only applies to St. Luke's Health System. It does not apply to all of the other health systems in Idaho. So this case is going to be continuing to work through the court systems. At some point, it will come up to the Supreme Court, and they will get to decide if people can basically die instead of getting the health care they need. And this isn't going to stay an Idaho case, right? Texas's ban has been a problem. If the court decides that people can die instead of getting abortions, I'm sure we will see other states following suit to tighten their bans. So it is still working its way through the court system. And right now, at least if you go to a St. Luke's Health System hospital, you do have that injunction in place, but it's still pretty dire in Idaho at the moment.
Yeah, I think, we've talked a lot about misinformation. And I think one of the pieces of misinformation that we often hear is that, people don't need emergency abortion care. But, both Jonas and I have been providing this care for many years now. And, we have a call system in place because even in our one health system in the state, we see emergencies on a weekly basis, every other week, and these are serious cases where lives are in danger. And so this perpetuating that myth that, oh, these cases don't really happen. They're taking this lawsuit for a non-reason. That's fake news, right? Like these cases absolutely happen. We've seen the ProPublica series that came out showing all of these lives that had been lost because they had received inadequate care. So that's a piece of misinformation that really frustrates me.
I think this is a little bit of the good news in a terrible situation of there has been so much coverage about that. So I think you are seeing at least people have a deeper understanding of abortion as healthcare in ways that hadn't existed before.
Yeah, I agree.
The other interesting thing or theme in that particular, what you were mentioning about St. Luke's Hospital, is it speaks to how both hospital systems and providers can be really hampered by their circumstances or by the place they work. And, I think sometimes you hear people saying, well, the doctor should just provide abortion, right? If someone's life is threatened, then you should just do it. Of course, you should just care for the patient and you should just go to jail. And that is people approach it as though it's quite trivial, and it really isn't trivial. And I think there's a lot of power in a hospital system suing and saying, this isn't right, and we can't care for our patients, and you're putting us in a position where we are hurting patients. And I was just looking it up. I mean, St. Luke's Hospital System, it sounds like, is not actually a Catholic affiliated hospital, but is part of a nonprofit.
Oh, good. You took that step because I was wondering.
Yeah, it's a nonprofit Catholic health system. But I mean, there is data to show that there are limitations to reproductive health care that people can get in Catholic hospital systems. And so I guess that I sort of feel in between about whether I know what St. Luke's is, but the fact that a hospital system in that state is saying, listen, this isn't safe for the patients that we care for to the state is a powerful move. And they're saying, look, we can't provide the care that we need to with this in place.
Right.
And you're seeing, especially you've seen in Idaho, a lot of their maternity wards closing. You have seen Idaho also shutting down their maternal mortality review board. So just an absolute recipe for terrible things to happen. And then people to not know about them because they got rid of the review board.
Yeah. Yeah.
Okay. The other case, the mifepristone case. So this is another case that was also at the Supreme Court last year. It was being brought by the FDA versus the Alliance for Hippocratic Medicine, which was a bunch of anti-abortion doctors. And always should remember there was some dentists in there because, that's who I always go to for my reproductive health care. I just always have to point that out. So it was challenging. Honestly, it was challenging the FDA approval of mifepristone. The Supreme Court was like, we're not looking at that broad. We're only going to look at the most recent expansion, which was the telehealth expansion, saying that people didn't need to go get it in person. The Supreme Court ruled that the Alliance for Hippocratic Medicine did not have standing in that case to bring that case. I don't know why they didn't think the dentists had standing. But so they threw it back down. Unfortunately, it went back to Judge Matthew Kaczmarek's court, which if anybody follows any things going through courts, he is very anti-abortion and will go out of his way to make the broadest ruling possible, hence the trying to repeal the FDA approval of mifepristone. He has recently ruled that Missouri, Kansas, and Idaho, who had filed amicus on that original case, could go forward as the leads on the case. So the case is going to continue to work its way through the court system with those states in the lead. There is still some uncertainty about if they can do that. I am keeping an eye on the case, but I also just, with who is in charge right now of all of the things, I could just see the FDA doing it without being forced to do it by judicial fiat. We could see some version of the Comstock Act being applied. This is a 150-plus-year-old law that was an anti-obscenity law, basically targeting pornography, immoral things. It does explicitly mention abortion and says they can't be sent through the mail system. So they could use that to try and prevent telehealth medication abortion, which I mean, y'all, that would be so devastating to abortion access in this country. We are already scrambling to cover for those 16 states where abortion is completely banned or almost completely banned. But if people had to go in person to get access, like the system cannot absorb all of that. It would be a real crisis point. So it is definitely something that keeping an eye on.
Yeah. Well, thank you for beautifully explaining both those cases. And yeah, those are cases that we're following too. And
I would just add one more, and it's flying a little under the radar. The Supreme Court on April 2nd is hearing Medina versus Planned Parenthood of South Atlantic. It is a case related to Medicaid. And for so long, anti-abortion advocates have been trying to defund Planned Parenthood. Like there's some sort of budget line that says Planned Parenthood gets money and not that they get funding for services provided through either Title X or Medicaid. And so states have tried to attack Planned Parenthood's ability to get Medicaid reimbursement. So this case is striking right at the heart of that. It is South Carolina, and they said that patients can't go to Planned Parenthood for their reproductive health services. The case is really bigger than that. Like it's bigger than just looking at sexual and reproductive health care. That is a big, important part and will, again, be devastating if patients can't choose who they go to. But really, it is looking at just like Medicaid, and do Medicaid patients have rights to decide who they are going to see for providers? And so that means low-income people, pregnant people, the elderly, people with disabilities. It is really impacting who they can go to see to access care. And while people may not think it's a huge deal to say you can't go to Planned Parenthood is often a place they take Medicaid, and that is a huge barrier right up front. Not everybody takes Medicaid. Planned Parenthood, this is what they do. They see people for sexual and reproductive health and family planning. They have those appointments down. They can see a lot of people. They have all of the method mix choices that a lot of other providers may not have. So it really is limiting people's ability to access care if they can't go to this provider. And we know that if the Supreme Court decides that this is okay, it will rapidly spread through anti-abortion states.
Yeah. And I think in some communities, the Planned Parenthood is the clinic that's there in the community that's been there for, decades providing care as the trusted provider.
And it may be the only provider that they see.
Yeah. And you're exactly right. Some practices don't accept Medicaid. And so those patients, may not have the same choices. There are many flawed and broken things about our medical system, but this would definitely make things worse.
Sorry, y'all. I'm such a bummer.
Well, I guess we could turn it. We're going to turn it around. We're going to turn it around.
Okay.
What are some things that keep you hopeful?
I get a lot of hope by seeing all of the work that is being done on the ground. I know that I am a person who I suffer really terribly from really big heart and really big empathy. And if I was on the ground and being that person who had to try and find people care and had to turn people away, like that is the way that would burn me out and break me. I don't think I could do it personally. So the people who are providing those services, the abortion providers, the clinic staff, the people who are running the day-to-day with abortion funds, the work they do every day gives me so much hope because I just know it is something that I couldn't do. And again, this is speaking to that. Everybody has to find a place where they fit in this moment. So you can't do all the things. And so find the place that works best for you. And I think so often advocates feel like they need to do all the things or they're a bad advocate. But I really don't think that's true. I think you find the places that are the place where you can do value add and do work. Like I know I can't do the big rallies anymore. I get anxiety. I start to panic and I'm like, I need to be out of here now. And so I just don't go to them anymore. But I always feel that like, you're a bad advocate. You're not going to the big thing and putting your body on the line and being out there. But I'm trying to be better about being like, you don't need to do all the things. So I do just get a lot of hope from the people who are fighting every day to ensure that people are getting the care they need, because there's just so many barriers right now, not including protesters that people have to deal with every day, or lack of funds. And I know that has become a real problem with, people were giving a lot of money right when Roe was overturned or when there's something in the news, but that is not a sustainable model. And with everything under attack right now, I think resources are going to become even more scarce. So I guess this is just my call to, support your local clinic and support your local abortion fund in any way you can. And I always like to add the caveat of, if you are able to be a monthly provider, even if it is just $5 or whatever, it's not just $5. They know they can count on that $5 every month and they can do their budgets.
One of the people that we talked with, Katie Watson, she sometimes talks about how this movement is like a mosaic. Like every person has like the thing that they're adding, and together we're creating this movement and this resistance. And so I think we each have our own skill set. You have an amazing skill set in creating this report card and the data, and then sharing out with the podcast, like what you're learning and what you're seeing. And so you are absolutely leading the fight in your own way. And so I think that's really an important part of the mosaic.
Thank you.
Well, we really, really are grateful that you took the time to be on the podcast today, and for all the work that you're doing, just as Bev was saying. So thanks so much for joining us on Outlawed. And I'm sure we'll hear more people should listen to your podcast, RePROs Fight Back. But then I'm sure we'll be in touch.
Yes, definitely. Thank you so much for having me. And I hope everybody goes to RePROs to listen to my conversation with Outlawed on our feed.
Yes. Awesome.
Opinions expressed on this podcast are our own. Philanthropy is helping us highlight these stories, and we hope you'll continue supporting this work by subscribing and sharing the show and getting involved in your local community.
This podcast is executive produced by us, Dr. Bev Gray and Dr. Jonas Swartz and Jane Marie. Production this time around is by us, so hope you enjoy. Thanks to Nick Thorburn, Patrick Ford, and Maker for our score, and Jamal Walton for original artwork. Extra special thanks to Jenny Wetter, who lent her knowledge to the show.